Welcome to the Cardiac MR Learner Series, a unique video tutorial program under the aegis of Indian Association of Cardiac Imaging. This program is focused on beginners and intermediate images with learning happening through short sessions and case-based discussions. We are grateful to experts from different parts of India who have helped us in putting this program together. Please do feel free to give us your feedback so we can continually improve such training opportunities. This session is brought to us by Dr. Vishnu Ravilla, who is a consultant radiologist and cardiovascular imaging lead in Care Hospitals, High Tech City, Hyderabad. His expertise is in cardiac imaging and image-guided intervention planning for electrophysiology studies. He is certified by the Society of Cardiac MR, CVCTA, and IACI, and has a publication in Indian Heart Journal. He has given multiple lectures at state and national level conferences and has conducted workshops on cardiac MR and cardiac CT for doctors. He is a trainer for DNB radiodiagnosis and has conducted multiple sessions for them. He is also an executive committee member of the Indian Association of Cardiac Imaging.
In this case series of hypertrophic cardiomyopathy, we'll be seeing different examples showing different patterns of involvement of the myocardium as well as different mechanisms which can cause LVOT obstruction in cases of hypertrophic cardiomyopathy. Let us first discuss the common scenario which we come across in our routine clinical practice. This will usually be a young male or female with history of syncopes who undergoes a ECG and echo which shows abnormal septal hypertrophy, and cardiac MRI is asked for us to evaluate the pattern and extent of the involvement in these cases. So the first case example is shown here. Here you can see there is significant and asymmetrical hypertrophy of the septum, mostly involving the basal septum. So because of this hypertrophy, you are seeing a turbulent flow in the LVOT, and if you also notice during the systolic phase, eccentric mitral regurgitation. First image here, you can see that the anterior mitral leaflet is actually moving towards the septum during the systolic phase. This phenomena is called systolic anterior movement of the anterior mitral leaflet, or in short form SAM. So these features are classical of a HOCM, that is hypertrophic obstructive cardiomyopathy. So here you are seeing basal septal hypertrophy along with SAM, eccentric mitral regurgitation, and a turbulent flow resultant of these phenomena in the LVOT. So you have to remember one more point in this context, that usually in a case of HOCM, you will find eccentric mitral regurgitation, which is secondary to SAM. A short axis sequence, the same patient showing abnormal hypertrophy of the septum seen in the basal segments as well as the mid segments. Also in the short axis views, if you see the basal sections where the mitral valve is seen, you can see the anterior mitral leaflet going towards the interventricular septum during systolic. This is again one more view where you can beautifully see the SAM, or systolic anterior motion of the anterior mitral leaflet. So the same patient on stir images, you can find intense hyper intensity in the septum, suggesting of edema. Same thing is pointed by the arrows on the short axis views. So identifying edema is very important in case of HCM, because these areas of edema are known to progress into scarring or fibrosis in the future. So always important to image for edema in case of HCM. So this is a short axis LGE sequence, which is a PSR sequence showing areas of enhancement in the insertion points of the interventricular septum. This is the anterior and inferior insertion points of the septum, and we are seeing patchy mid myocardial enhancement in those areas. So this is again one more characteristic feature in HCM patients. Patchy mid-myocardial enhancement in the hypertrophied areas as well as in the interventricular septal insertion points. So this is a case of classical HCM. Coming to the next case, this patient has a family history of HCM. So a ECG done showed deep negative T waves in the anterior leads, so suggesting there is hypertrophy in the LV apex. But an echo was done which was unremarkable, hence a cardiac MRI was asked. So cardiac MRI immediately shows you that the apical segments of the LV are significantly hypertrophied. You can see the 2-chamber, 4-chamber as well as the 3-chamber views. All the apical segments of the LV are abnormally thickened. Same patient on short axis cines. If you see the top row which corresponds to the apical segments, you can see symmetrically thickened LV myocardium, which is resulting in obliteration of the cavity of the LV apex during the systolic phase. This is characteristic feature in apical HCM. As expected, since the hypertrophy is in the apical segments, we don't find any obstruction to the flow in the LVOT. Again, as stressed earlier, stir images in this patient did show increased signal intensity in the apical hypertrophic segments. In the LG sequences, we do not see any scarring in this patient in the hypertrophic segments. So this finding of absence of scarring is very important for prognosticating this patient. So this is an example of apical HCM with hypertrophic apical segments showing edema. This is another case example where you can see the entire septum is abnormally thickened. Unlike the earlier case where only the basal septum is involved, this patient is showing significant involvement of the entire septum. You can also notice the RV free wall. Even the RV free wall is significantly thickened, significantly hypertrophied. Again, in the 3-chamber view, you can see the systolic anterior motion of the anterior mitral leaflet resulting in LVOT turbulence, and you can as well see eccentric mitral regurgitation. Again, the biventricular involvement in this patient is beautifully seen in the short axis views as well. You can see significant hypertrophy of the RV as well as LV, predominantly involving the septum. The LGE sequences again shows characteristic enhancement pattern involving the interventricular septal insertion points as well as mid-myocardial patchy enhancement in the mid-inferior septum. This is a case of biventricular involvement of hypertrophic cardiomyopathy. So next case is that of a elderly lady who is a known case of HCM, but now presented with increasing frequency of the syncopal attacks. So what was the cause for her increasing frequency of syncopal attacks? So in this patient, what we see on MRI is interesting. So you are seeing significant mid-septal hypertrophy, and also you can see the papillary muscles here. You can see the papillary muscles are arising from the apical segments rather than from the mid segment. So these two factors in this patient, namely the mid-septal hypertrophy as well as apical attachment of the papillary muscles, are leading to complete obstruction of the mid cavity of the LV during systole. Because of the mid cavity obstruction, the pressure buildup in this mid cavity is transmitted towards the LV apex. So since the LV apex is not hypertrophied in this patient, what happens over a period of time is the LV apex slowly bulges out. It slowly thins and bulges out during systole. That is what is happening in this patient. This patient is having mid-cavity obstruction because of mid-cavity HCM, as well as you are seeing bulging out of the LV apex during the systole. On short axis view, you can appreciate the mid-cavity obstruction because of mid-septal hypertrophy. So on giving contrast and acquiring delayed enhancement images, we find these features. you can see the entire LV apex is thinned out and is showing intense enhancement involving the full thickness of the LV. So this patient has developed LV apical aneurysm, which is intensely enhancing secondary to fibrotic changes. All these changes are the consequence of mid-cavity obstruction happening in this patient. So this scarred segment could have been the cause for increasing syncopal attacks for this patient. You can as well see on the short axis views the characteristic interventricular septal insertion point enhancement in this patient. Coming to the next case, this case is that of a 50 years old female who is a known case of HOCM, and she is being considered for surgical myomectomy. So pre-op MRI was asked for this patient for procedural planning. So in the fourth chamber view, we can directly see that the extent of the hypertrophy is not very severe in this patient. But on the fourth chamber, you also see one more important finding in this patient, that the papillary muscle is actually arising in the apical segment of this patient, and you are seeing certain eccentric MR as well in this patient. On three chamber views, you can again see that the papillary muscles are arising from the apical segment, and severity of the septal hypertrophy is very less. So what is causing the turbulence flow in the LVOT with such mild hypertrophy of the septum? So there are two factors which can contribute to LVOT obstruction in the absence of significant septal hypertrophy. So if you notice the anterior mitral leaflet and the posterior mitral leaflet, the anterior mitral leaflet is lengthier, or it's longer compared to the posterior mitral leaflet. Also, if you see the papillary muscle, it is arising from the apical segment. So whenever the papillary muscle is arising from the apical segment, and when the anterior mitral leaflet is long, they have a propensity to move towards the interventricular septum during systole, leading to dynamic LVOT obstruction during systole. Let us observe these findings in a short axis cine. So in this short axis cine, if you trace the papillary muscle, especially the anterior papillary muscle, so you are seeing the anterior papillary muscle in the mid sections here. If you trace it down, you are seeing that it is arising from the apical segments. Also, you can see, if you imagine this as a central portion of the LV cavity, and you can see that the anterior papillary muscle is actually migrated more anteriorly. It is more towards the anterolateral wall than the inferolateral wall. So this is again abnormal in this patient. So the factors of elongated AML as well as apical and anteriorly displaced anterior papillary muscle, these two factors combined together are causing dynamic LVOT obstruction in this patient. So because of this MRI, we were able to inform the surgeons that this patient would not benefit from myomectomy and she would need repositioning of the papillary muscles. So giving this important information is very crucial for proper management of this patient. Coming to a similar example, there was one more patient who had only mild septal hypertrophy, but nevertheless she was showing significant LVOT gradients to the extent of 87 millimeters of Hg. So a cardiac MRI was done. So the two chamber views in this patient showed an abnormal muscle bundle shown here, which was arising from the LV apex going all the way towards the LV base. On the four chamber view, you can see the hypertrophy is not very severe in this patient. The septal hypertrophy is only mild near the base. So on the short axis view, what you can see is the abnormal apical-basal muscle bundle. So if you start from the apex, look at the anteriormost portion, you are finding a bunch of papillary muscle tissue or the accessory muscle bundle. which is anterior to the anterior papillary muscle. This is the anterior papillary muscle. This is the apical-basal muscle bundle, which is very prominent in this patient. So if you trace that to the base, you can see that during systole, near the mid and basal slices, this apical-basal muscle bundle along with the anteriorly displaced anterior papillary muscle are coming towards the interventricular septum, leading to dynamic LVOT. You can see the turbulent flow in the LVOT cavity here. In the three-chamber view, you can beautifully see the abnormal and thick apical-basal muscle bundle. So this was arising from the LV apex and going and attaching to the base of the interventricular septum near the LVOT. So this was the cause of LVOT obstruction in this patient. Incidentally, you can also see the elongated anterior mitral leaflet of the mitral valve here. So whenever these combination of findings are seen, we have to suspect these dynamic factors causing LVOT obstruction. So the same patient, on doing a phase contrast, you can see significant turbulent flow in the LVOT during systole. So this patient was having LVOT obstruction because of prominent apical-basal muscle bundle. This graphical illustration shows how the apical-basal muscle bundle contributes to LVOT obstruction. So whenever there is apical-basal muscle bundle, the attachment of the anterior papillary muscle tends to be more shifted towards the apex. So this apical displacement of the anterior papillary muscle and the abnormal muscle bundle during systole, they can cause significant LVOT obstruction. So the treatment for this condition is surgical resection of the apical-basal muscle bundle and if needed, the repositioning of the papillary muscle attachment. Coming to the next case, this patient was that of a 50 years old female who had a long-standing history of HCM who is on follow-up, but the present complaints are increasing frequency of palpitations as well as shortness of breath on exertion. So what do you see on an MRI? On MRI, the most striking feature at the first glance itself is dilatation of both the atria. You can also see abnormal shuddering of the atrial walls. This is because this patient was in atrial fibrillation during the scan. And if you see for any hypertrophied segment, only the basal septum shows asymmetrical hypertrophy. Rest of the LV walls do not show any significant hypertrophy. So you can also note mild circumferential pericardial effusion. Short axis view, you can again see that the extent of hypertrophy is not very severe. Only the basal septum is hypertrophied. And on LGE sequence, you can see extensive scarring involving the anterior wall, mid septum, as well as the basal anterior wall, anterior septum, and inferior wall. And the pattern of involvement is that of non-ischemic etiology. So this patient, which was a known case of HCM, is now showing very mild hypertrophied segments as well as dilatation of both atria with atrial fibrillation. So on volumetrical analysis, this patient had decreased LV ejection fraction. So all these factors together, we can label this case of burnt out HCM. In this video, we have seen various forms of myocardial involvement in HCM. We have seen various causes of LVOT obstruction, both dynamic as well as static factors which can lead to LVOT obstruction. We have seen an example of burnt out HCM. We have seen how typically the pattern of LGE is noted in all these cases. And we have also discussed few points about the mitral valve as well as subvalvular apparatus, which can be abnormal in phenotypes of HCM. Thank you.